First of all, thanks to you, thanks to NECA for inviting me. It's really a pleasure and an honor being here with this public giving a lecture. I hope that I will give some ideas for the NECA and the healthcare system in Korea. This is a little outline that will be exposed now in my lecture. So just to begin, reminding what is considered as a health technology assessment. First of all, it's a multidisciplinary activity that examines systematically, it's an important question, an important quality, several concepts: the safety, the clinical efficacy, the effectiveness, cost effectiveness, and so on, as well as, this is very important because we are dealing also with organizational implications, social consequences, legal and ethical considerations. For the consequence is the application of a technology that could be a drug, could be a device, could be a program, could be different ways to act in order to recover the health of the patients or to prevent some diseases in the population. HTA usually is more related as a retrospective assessment approach. This is the classical HTA. If you see in the graphic how an idea is created here and how about a lot of ideas can arrive to have an experimental one opportunity, arriving to the investigational phase and later on to be established, to be put in the market, or eventually be by the healthcare systems. But we think that we can do not only this retrospective assessment, but also the kind of proactive HTA. What is said, the EAA is the early awareness, early assessment. And why not also to have a pre-label before the health needs assessment to know what is the needs the population have. Don't to be doing assessments about something that is not relevant for the population we are dealing with. And also without forgetting that when one opportunity is coming, probably there is another that should be replaced because it's already overseen. I will insist more in this concept. There are many categories or many issues that are assessed when we are performing technology assessment. First of all, the technology properties of the device or the drug or whatever, safety as well, the efficacy, which is the theoretical impact, and the effectiveness, which is the real impact of an intervention. And later on, we are considering the cost and the economic evaluation in a comparison with another opportunity, cost effectiveness, quality of life, and so on. But, as the previous speaker said, also the social, cultural, legal, ethical, organizational, or political impacts, or applying or not this new opportunity or this different way of organizing the healthcare. WHO, in a document, in a very interesting document, Health Technology Assessment of Medical Devices, present this graph. They are saying that we have several questions to be made about the technology. Can the technology work? It's about the technology performance. Can the technology work in this setting we are willing to apply? It's about efficacy. And this is what is looked by the regulators. They are dealing usually only with the technical performance and the efficacy. But in health technology assessment, we are going in a more longer run. We are looking more than that. We should ask two additional questions. If the technology should be implemented or not, that means effectiveness and appropriateness, and if the technology will be implemented in this setting this is the main role. These questions are the main role of the technology assessment. This is another way of representing these questions. Can it work? The device, the technology, the drug, the program? It's a question about regulation, safety, and efficacy, which is a requirement previous to the market authorization. Does it work? It's a question about the evidence-based healthcare. We are speaking about effectiveness. It's related with prescription. Another third question I mentioned before is if does it work proper than others? We are speaking about the comparison of effectiveness with another alternative opportunity. It's about provision. And the fourth one, which is more HTA related, is it is worth it to apply that. We are speaking about coverage reimbursement decisions. So decisions can be made in different levels. In a pedagogic way, we are speaking usually about micro decisions, meso decisions, and macro decisions, which is really strictly directed or related with prescription, which is made by clinical personnel, with provision, which is more related with directors and staff in the hospitals and healthcare responsibles and so on, and coverage, which is more related with policy making made by the ministers. So at the three different levels, this the macro decision is a big decision about to implement new units, new hospitals, new programs, but the prescription is the key of the door who opens the healthcare, because a physician, a nurse, is prescribing every time. Is said that maybe for each patient they have to prescribe 3, 4, 5 decisions. I mean, to ask for clinical analytics in biochemical, hematological, or whatever, to prescribe drugs, to prescribe physical examination or exercise or whatever. Each patient have many micro decisions, which is very important because it's conditioning all the other steps in the healthcare system. But decision has also overlaps. It could be taken on the basis of the existing information in the different steps. But the key here is that better informed is the decision. It will be more efficient and the impact will be better. So more the information, more the science we apply in the decisions, maybe we have a less of the part of the art was mentioned before. If medicine is the science and the art to cure, this is a balance of the art and the science. And I believe the decisions should be well informed before it should be taken. We have identified some gaps in the decision-making process when a technology is coming. We have the different phases for a technology, being initially an innovation, the phase 1, 2, 3 phases on the trials before regulation, because it's a necessity to demonstrate that it works in these phases. This is the regulatory bodies are asking for that. And the technology prospection could arrive to have this early assessment without very reliable information, but could be useful for these regulation decisions. We have this horizon scanning. NECA is a member of Euroscan and is very implicated in that. And we have later the post-introduction on the market decision, which are related with the reimbursement, the amount of money, depending on what, conditions for reimbursement, and so on. But also, the fourth question here is about if we reimburse a new opportunity, does this opportunity in the healthcare suppose a delisting or disinvestment of another existing one? So maybe we can have support from HTA giving some help and consultancy to the industry or the people who is generating new ideas in order not to produce something to be regulated without any important impact in the healthcare. Because when we are learning about the potential impact of a technology, we are reading about efficacy, which is the original value demonstrated by the industry or the people who is trying to sell this opportunity. But when we put that on the market, or we are trying to put on the market, we saw, or we can see that the value related to an incorrect purchase process, we diminish the impact from 20%. The impact, the really efficacy is 80%. The value related to over sophistication, so people is, in the other terms, to say buying this opportunity in 30% because this is over sophistication, as he said, and the real impact will be around 70%. By the end, we arrive to the real impact for a new technology. It arrived to be the effectiveness around the 40% about what it was promised in the initial moment. And in some countries, especially emerging economies countries or developing countries, they have additional two problems, which are related to the inexistence or replacement pieces or a lack of maintenance. So the real impact could be even lower than the other developed countries. So I mentioned before that it could be eventually, when new opportunities appear, it could be eventually have obsolete technologies, which is a health technology or application when the safety, cost effectiveness, or other concepts could be or have been superseded in a significant way by other available technologies that are coming to the healthcare system. British people represent in this way. They said when a new opportunity is coming, because the bed is already plenty of people, we should put one out of the bed. So if we need new technologies, maybe we can consider what is replacing this new opportunity. It's a graphic way of representing one in, one out. So we can identify new opportunities and identify potential obsolete technologies. Different ways of identifying these opportunities. One is a passive search, speaking with professionals and waiting what they are communicating as a potential obsolete or new coming technologies. And the other is to have a proactive search, which is performed by several HTA agencies, looking at databases, bibliographic databases, looking at different HTA reports, which are available in different portals, internet, INATA, Euroscan, Cochrane. There are many of them. Or going to the web sources, which are provided by industry and new providers. We did this exercise a few years ago. We did this obsolete technology identification project by ourselves in OSTEBA, and the objectives were to identify the possible sources of this active information identification for obsolete technologies and trying to prioritize the most important ones. It was published a few years ago in the Health Technology Assessment Journal, and we had some conclusions. The first approach, it was at that time the first approach to identify sources of information for obsolete technologies. Nowadays we have different sources, hopefully, and at that time not many agencies were working in obsolete technologies. Nowadays we have different groups, even in the Health Technology Assessment International Society, there is interest groups working in this domain. And the sources of information were mostly indirect, no specific for obsolete technologies, but looking at the horizon scanning database, looking what is coming as new opportunities, we can identify opportunities to disinvest, the replacement. So we think that similar sources for the devices, diagnostics, and programs, but we have little information about drugs and the disinvestment of the drugs because new opportunities are coming. So in this exercise, we identify in this period more than 1,000 technologies that could be obsolete. Almost 300 were classified as substitutive, and we are performing more studies about searching in the HDR reports about new technologies and the clinical guidelines recommendations that are mentioned what is better to do and what shouldn't be done. And you will have a source of information about what could be already overseeded by new opportunities. Continuing in this way, we made a collaboration with another regional agency in Spain, which is in the west of Spain, the Galician region, and we published that, identification and prioritization and assessment of obsolete health technology, willing to be a methodological guideline. But the other agency in the south of Spain, we are colleagues and we are working in network and collaborating with each other. They published these interesting guides about new technologies in hospital. This is the guideline for acquisition of new technologies, the guideline for genetic technologies, and the guideline for incorporating new drugs. So we went a little bit further in OSTEBA, and we tried to define which criteria should be taken into consideration when we are assessing this kind of technologies, including all the stakeholders in this process, and we identified the GUNF, we call that the GUNF guideline and a software. The software and the process is like I will expose now. We can receive application forms for disinvestment or for new technologies. It could be received by email, by the application, different ways. We assess that in order to check if we already have identified that, and if it's necessary, we can do a prioritization to identify or to have an idea about what could be more pay value doing this identification or this assessment among all the issues that were identified. We do this assessment report in order to give a final decision report for decision making. Decision making, I repeat, in the 3 levels, depending on the question. More devoted for clinical decision making, for management decision, or for policy decision. And it could be a positive or not as positive guide for the action plan. We have a software helping to this process that help us to identifying the processes and the proposals, and also giving and connecting the abstracts we produce with Euroscan, with INATA, and so others. So when we are assessing low added technology, health technology, we should take into account 3 aspects of this to be evaluated. This is related with the service package already defined and the strategic objective for the own regional, national, or federal strategic objective, and the balance between the advantages and disadvantages of evaluating that, and the ability to carry on this proposal and the possible impact on the decision to be made. We have few anecdotes about being asked to assess something that was already decided. So we produced the final report knowing that the decision was made. I don't want to mention the case, maybe in a private way, but the politician was already decided something. And sometimes the minister said to me, Jose, I want you to assess that, but I know this works. I said, well, this is evidence-based medicine or evidence, because you already see that medicine-based. So the minister has seen in a trip in the States that some technology worked, and he was convinced. So it was no way of doing any assess, but they were willing to ask to us to do the report. But it was not comfortable for him, because we were based into the scientific evidence that was not painful, that was not effective for us. But he has already the contract sitting down. This is not comfortable. So who should be involved in this process? If decisions are related with managers, decision makers, and so on, these different actions, and we propose some methodologies, we use that, but there are many others that you have also in NECA. We think that there are many responsible people related with the different phases or actions to be made. For example, to identify opportunities to be delisted or to be disinvested is any health professional working in the healthcare center. Checking application prioritization is more related with our task in technology assessment agencies, and decision-making and activities plan is more related with the managers, multidisciplinary groups, involving patients, involving values, and so on. This is the guide we developed about the non-funded existing technologies, and it's available in English, also in this URL, and you can go to the OSTEBA link or in NATA, and you will arrive here, and if not, you can ask to me or any other colleagues in NECA, they will provide you that. But these decisions that should be made in the healthcare system also have some gaps related with different phases. Before the regulation, we have gaps in the technology prospection, gaps in the requirements of the systems that eventually could be incorporated to the healthcare system, and also gaps in defining which are the health needs the population have. We should assess what is the real needs for this population. And the horizon scanning is also an activity that could be taken into account. From regulation to reimbursement, there are gaps. There are back door, which is the door for many of the technologies going to the hospitals. So maybe the early dialogue is a way to be more transparent and saying, we have a need, this need for our system. Industry, what do you have there? Can we collaborate and try to define more precisely which are the needs we have and the technologies you have, and put together all the need in order to go for the objective of the public healthcare system. We have gaps also in reimbursement and investment. Maybe health technology management and the post-introduction observation are two ways to be more aware of this reimbursement and looking at the real effect of the new opportunities once being applied and in the clinical practice. And also we have this investment and innovation is more related with the health impact assessment and the continuous evaluation of the effectiveness and efficiency of the opportunities. So maybe it's a way of doing a graphic representation of what happened in the healthcare. So we have the research, dissemination, and innovation, and we have the technology and maybe the early dialogue. We have the preclinical research and the clinical research. the clinical trials and other epidemiological designs are trying to define what is better, what is less good than it was thought before. And we have the regulators. So we have also the HTR report, which is looking at when something is regulated, how it's going into the healthcare system. And we have also the analysis of the appropriate use, variability, not adequate prescriptions, and so on, which is more related with the clinical practice guidelines and the post-introduction HTA, which is also called the reassessment. And is giving some keys or some clues for the disinvestment and some ideas to replace some existing alternatives. So another question to be taken into account is who is the customer of the assessments. For ours, it's always the public, but eventually there are other agencies working also for the private. So one, the public is not making money, is making health. The private, maybe the goal is make money, make employment, make richness, and so on. But it's a perspective that should take into account. Economists are really aware of that. The customer is the provider or the purchaser. Are our customer for the health technology assessment the professionals, the managers, the patients, the citizens? So the information provided, that should be provided, maybe is originally the same, but it should be transmitted in different ways because of the background of the different people and the objective they have in the decision that should be making. So health technology assessment is working in these three decisions continuously, but it's important to take this in mind, that is closer to decision, that is thinking about the sustainability of the healthcare, especially the public healthcare systems, that we can have impact in provision healthcare. We should increase stakeholders' involvement in these processes of decision and have not just recommendations, but also involvement in the implementation and the future coming evaluation about once the decision is made. So having always in mind that we are doing assessment, but we can do also reassessment once this is implemented, taking in mind the life cycle of the technologies. So there are different agents or people having decisions. We have the society, which is demanding healthcare. We have the clinical practice, which is also demanding more and more opportunities. And we have decisions to be made in the provision. We cannot put that on the basket. There will be some decisions in order to have a healthcare system more sustainable and more close to the needs of the population we have. And maybe health technology assessment is a tool that could influence these different needs, perceived needs, and decisions to be taken. This is one of the representations of the life cycle of the technologies, having here the research and development, the experimental technologies, the innovative technologies, and once in the market, having this clinical engineering and post-marketing surveillance in order to have this surveillance about which are the ways of doing clinical practice. Are we doing really the effectiveness is close to the efficacy, or we are very far because we are not applying in the appropriate way? What about the learning curves? What about the other opportunities they have in the same hospital and so on? And having also this in mind, the obsolescence and the possibility of replacement. There are many initiatives already in practice. We have horizon scanning, early awareness system in Euroscan, in HTI. We have early dialogue opportunities in the UNETA, it's a European network for health technology assessment. We have also initiatives in the incorporation step, which is innovative purchasing process. They are mentioned two ways, coverage with evidence or risk sharing agreements with the industry, saying if it works, can we share the registration or the benefits later on, because industry needs patients and the patient needs opportunities. If it's not still in the market, we can share this interest with this innovative purchasing process. And we have also initiatives in disinvestment. So we are many HTA units. In Spain, we have 6 units or 6 agencies, but we are collaborating in networks. We are very similar in methodologies, but different in the ways of transmitting information sometimes. Different because how we are relating with the customer, how we are producing information, how far we are involving stakeholders in the identification, in the assessments, and also in giving the information which is needed for the decisions, and also different ways of having the relationship with other HTA agencies. What can we share? I am convinced that we can share for sure the methods and the evidence. In the macro level, because they are core elements, their implementation, the implementation is maybe low, and we have low impact in provision and prescription. In the meso level, we need use the evidence, doing more benchmarking, and analyzing more the impact on provision. And maybe we are arriving to the low impact on prescription. In the macro level, which is the clinical decision, we need benchmarking, we need to improve the high internal validity, but the external validity usually is low, but we can arrive doing this evidence, arrive to the high impact on prescription. Some ideas, just to conclude. I think that health technologies should be considered as a whole, and the life cycle of technologies is a more appropriate concept that we can incorporate in our minds, and different processes are comprised. Identification of the health needs, innovation, effective implementation of the different technologies, and also looking and analyzing at the listing or disinvestment of the technologies for low added value or not added value. As a conclusion, to say that the context is very important. So the information could be general, could be international, but the decision is local. The same evidence could lead to different recommendations, dependent on the context. So health technology assessment is needed in the 3 decision levels, but the information should be transmitted maybe in different way. Health technology initiatives that have been focused only at the macro level are not as successful as is previously considered. So we need to identify more appropriately which is the customer and fit the needs of the information they have. And we think that there are very high importance of the combination of different methods, even in doing the research, doing the assessment, doing also the transmission of the information, using qualitative and quantitative methods, as it was mentioned before, the art and the science. Thank you very much.